You want to introduce your panel there, and then I'll kick it off here? What do you think?
Sure. We've got John Runback, we've got Eric Sasemski, Fabrizio Finelli, Kenneth Rosenfield, and we've got Peter Ferrugia that just showed up here. Hi, Pete.
Fantastic.
So we've got an all-star panel for you. Hopefully you weren't doing STEMIs like last time before starting your case.
No, we were pretty busy, I will say that. But welcome to Kingsport, Tennessee. We are thrilled, Sheree and PK and everyone, to be transmitting live from Kingsport and Ballad Health to New York Endovascular Symposium. I think we have a great case. I'm glad I have friends and experts to help us because we'll need it. Let me introduce our team that got here early after being here late last night. To my right, scrubbed and running the table and actually organizing the table and smacking my hand when I interfere with it is Alexis Mullins, and that's a true story. Behind us, we have the talents of Jessica Linkus, who you'll see her beautiful runoff skills in just a moment, Victoria Miller, Jordan Lambert, the nursing talents of Michelle Tolliver, and then my good friend and partner, Dr. Gaurav Rana, who played an integral role that I'll show you in just a moment. It took him 1 minute and 59 seconds, I believe, Gaurav, for a very important part of this case, which we'll show you in just a moment. All right, without further ado, let's go to our slides here. All right, here are disclosures. Next slide. This is a very nice gentleman we've had some adventures with before. He's only 60 years old, severe PVD. He initially had a CTO of his right common iliac artery and had calcified disease in his left, treated in 2016 with my partner, Dr. Mark Aziz. Later, he had left SFA and popliteal occlusion throughout their entire length that we treated for severe symptoms as well. More importantly, I met him with left hemispheric strokes. He had literally 15 events in a small left hemispheric stroke and had a 95% left MCA stenosis, which we treated and we'll show you briefly. He has the other risk factors that you see there, long-standing tobacco use, recently declining, and we are counting on an adventure of non-smoking starting tomorrow. All the other symptoms on the left leg and neurologic have resolved, but he's had, since 2020 when we did our other work, occlusion of his distal SFA and popliteal that was treated with maximal medical therapy, but now he has severe symptoms. Next slide. Here's ABIs, 0.57 on the right at rest, drop severely with exercise. On the left, they remain normal with rest and exercise. And again, he's maximized on medical therapy and a walking program, and he comes in for the right leg, which we've known has had a problem since at least 2020 when we first took pictures. Next slide, please. Here's the initial adventure. You can see the right common iliac artery CTO with calcium on the left as well. We always use triple axis for this kind of scenario and crossed it from the arm and then put kissing stents trying to preserve the bifurcation. Next slide, please. Here you can see the CT angiogram of his left MCA, severe stenosis on the angiogram above, and then we did submaximal angioplasty on that, and again, completely resolved. That's been 2 years ago and really worked out well for him. Next slide, please. Here's his left leg that we worked on before. You can see an occlusion at a branch in the distal SFA, the entire length of the popliteal, and it came back at the trifurcation, as you can see the second arrow. Next slide. We were able to cross that, treat it mainly with DCBs, one short Sapera interwoven stent, and I think a nice final result there. Next slide. And now we'll go on to today's case. So let's go to what we've done so far here, please. So we always use micropuncture access, as everybody on the panel likely does. Here's his left SFA. He's got left common femoral, some disease, but not bad. Here's a picture of his left intervention from 2020. You can see there's a little cleft in the TP trunk, but again, ABI is normal. Everything else looks pristine with a DCB, and you can see a short Sapera stent there. Here's his aortogram. You see a little calcium at the bifurcation near the stents that were placed in 2016. Here are those stents that are still patent. And then to get to the right, here's just carefully engaging with a marker Omni. Even with a wire very deep, the Omni wouldn't go, so this is just a navicross going up and around. And then this is a 7 French curved ansel, carefully going from the stent on the left to the stent, through the stents on the right. You see we had to do a little walk the dog maneuver to get that through there. And then here's the right leg runoff angiograms. Pretty good SFA, pretty large. And then unfortunately, this reminded me today where that occlusion is. It's really at some major side branches with no nub. If you wait long enough, it comes back in the underfilled mid-popliteal artery, and predominantly one vessel runoff via a posterior tibial artery, which supplies the foot very nicely. Here are some oblique angiograms, as much as the Phillips lab that we have would allow us to go oblique without getting equipment in the way. And even with a steep RAO, you can see really hard. Maybe you guys can see it if you can. If you got a laser pointer, point to me. I don't see the nub. And then here's a left oblique. And again, I'm not doing much better to find the nub there. And you can see the delayed reconstitution and late filling of the underfilled popliteal artery. And finally, here's the calcium that we see downstream here. So let me throw that over to the panel here and see, with this occlusion, what access would you guys, what are you thinking about crossing here? We'll get later into what our strategy is once we get across. But crossing technique, what do you think in terms of how would you do this?
Thanks, Chris. Great presentation. Maybe we can go down the panel. John, you want to start? We have obviously an ambiguous proximal cap and a P3 segment pop reconstitution. What are your thoughts?
Sure. So first of all, I'll let everyone talk about that so we all get our fair shake. But I just want to compliment you for placing those iliac stents the way you did. I mean, you know, the natural tendency on these things extend up into the aorta. You were perfectly flush. You preserved the option of coming up and over. So I think that right there is an important take-home lesson for people who don't do a lot of this work. So I want to compliment that, and then I'll let everyone else sort of go down the panel here.
So thanks, John. I think you're right, though. You've got to preserve that because he's got a lot of disease.
Chris, if I could just ask, what did you get? This is Pete Ferrugia. What did you use? Which wire did you use to get that ansel up and over? Because that had to be very difficult.
So what we did is we just took an angled glide wire to steer.
Okay.
And then we used a supercore. If you get the catheter deep enough, you can usually get the supercore. If it starts pulling it back, the catheter back, that's when we use a glide wire advantage because it'll still give you the stiffness, but it doesn't pull things back. But we were able to get our wire deep into the SFA. And then we were able to get a supercore by holding things close and then just go up. And we used a curved ansel, and you saw we went under fluoroscopic guidance very carefully.
Yeah, I mean, I was thinking maybe using a Benson just because of how stiff that the supercore would be to kind of kick you back, but makes a lot of sense. I'm going to cheat and say I agree with PT access here to kind of come up retrograde to try and cross this because of how ambiguous the proximal cap is.
Great, thanks, Peter.
Ken?
So for the sake of moving on, I'm going to let you guys keep talking. I want to work, and I will tell you that I think that with the ambiguous cap and the fact that it took a long time to refill the pop and it's fairly small and underfilled, I really wanted to go retrograde. Even if we can't cross all the way, I really think that if we can go up higher and meet in the middle somewhere, we're going to be better off than crossing an ambiguous cap and then poking at an underfilled popliteal artery. So our approach, and that's where Gaurav came in, and I'm going to let you guys talk as I work, but I use vascular ultrasound for every access except tibial. I've been a long, old guy that watched Andre Schmidt say, yeah, and we poked at the artery. But I've got younger partners, and Gaurav Rana came in, and literally in 1 minute and 38 seconds, whatever the time was, got beautiful PT access, and then usually we'd go bareback, but for the live case and all the complexity of this, we're going to use a very small sheet. We're going to get to work while you're talking and giving opinions here.
Thanks, Chris. What would be your approach, Ken, if you were looking at this case?
I was going to ask Chris whether you thought about doing antegrade here because he has a really nice common femoral, and it's a heck of a lot easier to cross antegrade. Antegrade in the common femoral. He's muted.
No, we can't hear you, Chris. I think you're muted.
But you do great sign language.
How can I be muted?
There you go.
Great sign language.
All right, can you hear me now?
Yes.
All right, so that's on you, buddy, because I don't have a mute button. I'm not zooming. So the only problem with antegrade, Ken, is that you don't have the profunda collaterals because your sheath tip is beyond that. And so that's why I'd rather go contralateral. I think it's a good idea, but I like seeing the robust collaterals from the profunda that refill things, and that's why we went the other way. But you're right, you could do it that way, and it is easier to cross there, and that was our second option if we had trouble getting through the stents.
Yeah, I just find if you're dealing with the total occlusions, especially below the knee, that it's a lot easier to do antegrade. You have a lot more options. You have a lot more control, in spite of the fact that there's great, crossover sheaths and so on now. So that's point number one. And I think you can get good closure now with some of the devices out there, like the Kelt device and others. The other thing is I think you can get backflow. You don't have to put in a long sheath, and you can put it in just into the proximal SFA and get good reflux back over the profunda to show where your landing zone is. And then finally, in terms of the actual occlusion, I understand. Before antegrade, I guess I'm an old dog. Before retrograde access was popularized, I must have crossed 1,000 of these damn things antegrade, and I think you can get across, and you can do a good job. I probably would probe it and do it antegrade first, make an attempt, and if it wasn't working, then I'd go retrograde. Although I respect the current sort of wave of thinking of going retrograde. You're much more likely to get in retrograde and not extend the dissection.
Yeah, and I think there's a couple, for the fellows out there that are training, a couple of really good points on this case. One is, like John brought up, the aortic bifurcation was preserved and not elevated when that iliac was fixed, because you're going to go up and over, or have to go up and over at some point on either leg. As we know, these patients, they come back regardless of optimized medical therapy. I think the other thing is ambiguous proximal cap. This is a tough CTO because it crosses the knee joint. It's another thing to think about. I think the proximal cap's ambiguous, a lot of large collaterals coming off of it, but like as John showed, whether you're subintimal or doing intimal recanalization, you could start this one subintimal and use various techniques, reentry devices to get back in. I think a lot of people, another final point would be, is a lot of us in this case who remember is a Rutherford 4, right? This patient has rest pain, even though they've got class 3 claudication. They also have rest pain, no wounds, no ulceration, no gangrene. So this is really, in effect, a limb salvage procedure. So I think going retrograde makes sense. I think improving this inflow will make a big difference. Michael, what are your thoughts on this case? In terms of your approach as a vascular surgeon, how would you approach this case? Any differently?
No, I think everyone's mentioned such insightful things. I think one other consideration for access would be considering the anterior tibial artery, which was occluded on the initial arteriogram. This is a patient with single vessel runoff. This is a limb salvage procedure, and while retrograde access is, very safe, you can run into situations where you can damage that single vessel runoff. So using the anterior tibial artery as your access site could be another consideration to preserve that posterior tibial artery.
Dr. Finelli, what are your thoughts on this case? Would you have accessed that occluded anterior tibial and done a kind of almost like a modified Schmidt technique, right? We don't have a stent here, but we're accessing an occluded artery to then do your recanalization, preserve that single vessel runoff in somebody that has, BTK disease?
Yeah, regarding the femoral approach, I agree with Kenneth that maybe the antegrade would be my preferable choice. There's pretty enough room to put a short introducer, and then you can use also something longer to have a better support to perform or to try to have an antegrade recanalization. I will try a couple of times, to go antegrade and the luminal subintimal. This is something that you can see during the procedure. Also because going antegrade, you can avoid to work within the stents, because this is always, a question mark that you can create some damages inside. Retrograde is great, but as it is a single vessel runoff, in my opinion, if I remember well, there was a pretty large collateral in the AT area. This could be my target, just to avoid to touch the posterior tibial. This is the only one bringing the blood to the foot.
Yeah, no, it's a great point. And a lot of people do antegrade CFA and antegrade proximal SFA as well, nationally and internationally. It's quite safe. Chris, could you tell us what catheter systems you have and are using, and the guide wires, your escalation strategy, 014, 018, et cetera?
Great question. So we started from above. I like 035 angle glide or straight glide, depending on what we can do with this catheter. From below, we used an 018 wire. We have a Navicross, which is usually what I'll do bareback, an 018 angled Navicross, and we have a Command 18 wire. I like a V18 as well, but there's a bad marriage between the V18 and the 018 Navicross for some reason. So I've done long work, as we've been parts of before, where we went all the way around and then the wire was completely stuck in there. So this is an 018 Navicross angled and a 018 Command from above. Now we're going to try to meet in the middle somewhere with a angled Navicross. And now that crossed antegrade. So now the good news is we crossed antegrade here. I think we crossed somewhere good. We're about to find out together. But you saw that. I'll just play that back again. I think I'll play it back here.
Chris, everybody talks about staying in the true lumen if you go retrograde, but I think this is a good example of the fact that you don't always stay in the true lumen if you go retrograde either. Actually, it looks like you got through antegrade.
Yeah, I think so too, and here it comes. Now, I will say that I think we're in a true lumen there, so if anything else this gives us the option of meeting in the middle if we have to, where we know we're in a true lumen, somewhere that's above that pop. So let's just see if this will track down.
Retrograde subintimal course may somewhat limit your ability to kind of get down on the bottom. Sometimes at this point you have to pull back that retrograde catheter.
Yep.
So you can.
Yep, no, for sure.
Yep.
And one of two things can happen here, John. We can either try to meet in the middle here and just put our retrograde wire into this sheath, or we'll leave our wire position here. As you say, bring the catheter back and see if the antegrade wire will now track the wire. Because I know, I think I know that. Oops, wrong. Let me pull the right catheter. All right, come on over here if you would, Alexis. But I pulled the wrong catheter for a moment. I'd rather not do that again. So let's see if we can just maintain our wire position retrograde, bring our catheter back, and see if this wire will track antegrade. If it does, great. If not, then somewhere in the middle, we'll try to steer into that. If that doesn't work, we'll cart and then reverse cart and whatever else we need to do.
By the way, I was just thinking, the comments, about the single vessel runoff. So we tend to do these sheathless, just go with a 2.6 or 2.3 microcatheter. So, put as little as possible, preserve antegrade flow. I don't want anything that's going to be occlusive in that single vessel runoff while we're working. So just a thought.
There you go.
No, I think that's a good thought.
Very nice.
Now, the only question is, I don't want to extend this. This is almost just like a regular CTO crossing, but I don't want to ding this up antegrade. So that still doesn't feel good. So I think we're going to meet in the middle somewhere here. And what I think we're going to do is just cart this.
I have to say, sometimes I find that the angle glide wires take me outside the channel, and sometimes a straight actually just finds the channel. There's so much variation in technique here, and sometimes a Command 014 wire works really, really well. I mean, I'd be interested to know what other people do. I always learn so much when I watch you, Chris.
Yeah, but I think that also at this point, as you have also the retrograde access, you can also catch your Y, grab your Y, because otherwise there is a risk that you can destroy completely going antegrade and make no sense.
Yep.
Interesting thing is, once you get to this point where we say it's just a matter of time now. I mean, you've seen the one wire move with the other catheter, so you're just going to have to manipulate this and maybe dilate, make some space, whatever you want to do. But it's just a matter of time once you're in that rendezvous zone now to connect the wires and finish the case.
Yeah.
So, Chris, you were talking about cart, reverse cart, et cetera. Where are you going to perform this based on what you've seen, right? What do you think is the optimal location based on the collaterals, based on the reconstitution point, et cetera?
I think we're going to start more proximally. We don't want to balloon too much distally unless we have to, but we'll take it one step at a time. One thing I'll show you, maybe you can show here, I'm seeing blood in my antegrade catheter. I don't know if you can zero in on that. So because of that, I'm going to try to finesse this rather than brute force it. And so we're going to take an 014 command and just see if we can finesse this from antegrade. If we can, hot dog. If not, then we'll figure out, as John said, a different approach. Can you show on that zero in there, Dylan?
So one thing you don't want to do, and this is for people in the crowd, and I've seen this happen at my institution very recently, is an injection, a strong injection. No. Because the hydraulic, I mean, believe me, people say, oh, where am I? Let's inject and see where I am. Then you end up with just a hydraulic dissection. It's awful.
Maybe we can go down the panel. What is your, the panelist guide wire escalation strategy for CTOs? You start 014, 018, 035. Does it matter at this point?
Well, antegrade 035. Retrograde, we prefer 014. 018s are great, but I found that sometimes it looks like it's going, and then it's actually not in anything, whereas the 014s tend not to do that. So we use commands primarily, then we like advantages, and then we start getting into our, heavier tip wires, particularly if it's straight or we can steer it.
Supercore like that.
I prefer from above an 018 strategy. I'll quickly move to an 035 if we're not getting anywhere, but the smaller the better. I don't think you're going to start with an 014 from above, but certainly starting from below with an 014 makes a lot of sense, again, with the same strategies in mind.
Ken?
I'll usually start with I already said it, for CTO, I'll often use a straight, stiff glide wire, which the tip of which is not that stiff, actually, and with a catheter to help guide it. But honestly, I think I'm much more inclined now to sort of convert to 018 or 014, even antegrade. I mean, there's such amazing wires for the coronaries, and using those in the periphery, it really works well at times.
Michael?
When dealing with SFA or popliteal CTOs from above, stiff angled glide wire, support catheter, and from below, predominantly 018 wires. I'm a big fan of the 018 glide wire advantage and the 018 command wires. I think those two combinations from above and below, you can get through 99% of things.
Fabrizio?
Fan pop, 035 from above. Going from below is 014. And just in very challenging cases with a lot of calcium, also below the knee, we use an 035 stiff guide wire.
I think the point here is it just shows you there's a lot of different escalation strategies for guide wires, which we all know. And Chris had mentioned cart and reverse cart, for the fellows that are out there, we wanted to make sure we described that. Obviously, we've got two systems, one from above, one from below. They're in two separate subintimal planes. And so the idea is we have to create a connection or communication. And so, with reverse cart and cart, you're putting a balloon from one direction or the other. You're enlarging that subintimal space, and then you're using either a guide wire catheter-based system or a reentry device, et cetera, to basically gain access from one subintimal space to the one that you just dilated. And so that's basically what Chris is talking about, and you're going to see that in action here. And
just to be pragmatic, if I may, working a lot of OBLs. So, we use the 035 catheter antegrade and don't hardly ever use a balloon. You can knuckle that 035 wire and sort of keep within that rendezvous zone, separate that kind of thin cell layer between the two lumens and never have to use a balloon and save on that money. And we go retrograde 014 for a variety of reasons, one of which I said, but also now that will generally more easily enter the 035 lumen.
Yes.
And save you on a wire on that side. So, we pick these things up front, thinking about a lot of things, including the cost of the devices. So,
does anybody here use the glide wire Gold? Sure. It's an amazing wire. That's an old wire that is actually tends to find the channel. I know that Doug Drockman, you know this, Eric, but Doug uses it all the time. I introduced it to him like 20 years ago. It's an amazing wire to find channels. I'm just curious if anybody else had any experience with that.
Hey, Chris, we're watching you do your work here. Can you describe what you're doing and which technique you're using at this point for everybody that's watching?
Yeah, I'm doing what I like to call the balloon and hope technique. So we're going from above with a 5.0 balloon. Now, and the other thing we're doing is we're using some angulation. And PK, if he's out there watching somewhere, he isn't master it. And we did a really tough endomasters case here. And what will really surprise you is what looks optically beautiful in one view looks optically terrible in another view. Okay, come on down. And so I'm angulating a little bit, and now we're just from our antegrade, we've got an 035 wire in from above, and I'm just dilating that occlusion that we know we cross go up there. And so this is just a 5.0 balloon doing sequential inflations.
And Chris, talk about balloon sizing when you're doing cart and reverse cart in this case, obviously in the FemPop here that we're talking about. How do you decide?
So we could get a lot of people use bigger. This is kind of a moderate Goldilocks, not too much, not too little approach. So this is a 5.0, and what's for sure up top, it's a 5.5 or 6.0 vessel. Come on down, please. So what do you all think? Bigger, better, or smaller? What do you think?
I think your size is right, but I'm wondering, since you have that retrograde access, if you would consider doing a retrograde antegrade balloon overlapping to really disrupt that septum, you know, that's sort of very popular technique.
That's our very next step. We've got that balloon prep, John. So what I'm going to try to do now is just see if with just pulling the balloon back, that now I can redirect my retrograde wire. So I'll trade places with you. We're doing our tibial two-step here. It's a Tennessee maneuver.
So Chris, probably while you're doing this and everybody's watching, maybe we'll get through one or two talks if that's okay for you. Is this a good?
I think that's a great idea.
Right,
this
great.
is a paint dry kind of part. So
Okay.
yeah, I agree. And we'll floor save anything we need to.
Okay, great.
Let me take you back to where we left off. Maybe you were watching on screen. John Runbeck was correct when you say, hey, we're somewhere in the middle here. You know you're going to make it. It's just a matter of, do I get a bead of sweat while I'm doing it in front of my friends? You can see here, we tried to cross retrograde. We didn't get there, but you can also see that we were definitely hitting the wire. You can see that right there. See that? We're hitting the wire. Boom, boom. So since we couldn't get the retrograde, now we took an angled nav across from above and tracked the wire antegrade. And you'll see that in just a moment. I think it's some of our floor save on a new system, 20 or 30 seconds. Now you can see the wire going easily antegrade there. Here's a confirmatory picture, antegrade into the anterior tibial. So what we've done there is taken our retrograde equipment out, and we're working antegrade. This is a 40120 chocolate balloon, just to kind of get an idea where we're at. And two inflations with that. But remember that mid popliteal and distal popliteal are pretty small. So we'd like to do DCB if we can, but we also want to make sure we're doing definitive therapy. And I can tell you with our cart there, while distally we're going to go DCB, that's a little bit of too much of a dissection for Chris. So we have a beautiful stent that we think works spectacularly in this system. I'll let you guys opine on what you want to do. What we're going to do now is do a DCB, and then we're going to pick that optimal stent amongst friends and then see where we go from there.
Chris, how do you do your sizing in this case? Because this is it's a tough CTO, right? It crosses the knee joint a little bit, and
yeah. So, yep. So we have IVUS open, and depending, and Eric is a good friend, and he's been down in our lab. We've had some fun together. I think IVUS is great. Depending on our timing, we'll do that. I think that distally, I will tell you that with the stent that I want, I'll just blow the secret and spoiler alert. We're going to use a Sapera, no question on that. So with Saperas, it's going to be a 5.5 whether it wants to be or not, whether it wants the IVUS to be or not, because I don't put small Saperas in. And so we just have to pre-treat that. But I think for distally, we're going to go with the DCB and we're going to go with the 5 because we want to be at least 1-to-1. And then IVUS and experience is our key. I think that the SFA, and we could confirm that depending on time with IVUS, I think the SFA at the point of occlusion is probably a 6.0 vessel. And I will say that the Saperas, the 6 Sapera, now that they have half sizes, I think does a remarkable job for that. This balloon, just so everybody knows, is a 5x150 Medtronic 018. They now make an 018 variety. Okay. And that's what this is. And we're going to do a roadmap, and then we're going to go on that. So let's go ahead and take a picture here. Ready?
maybe we can get some opinions from the panel on how they would approach this.
Sure.
lesion.
So we're superior sycophants for sure. It's always interesting how you so aggressively dilate the popliteal artery in a potentially what would have been unsafe manner, planning to put that scaffold in. In this particular case, it's interesting. I thought you were going to say Mimics 3D because, there's a big discrepancy between the caliber of the vessel higher and lower. You're going to get some elongation of your superior down below, and that obviously compromises patency. Those are two possible choices here in bare metal stenting. I might have gone on Mimics in this case because of that tapering of that vessel. So,
interesting. I think an important consideration has to be where do you want to start it and where do you want to cut off the stent. Knowing that there's a significant size discrepancy, obviously we always do our best to avoid stenting across the knee joint itself. But I'm superior all the way here. I don't think anything else belongs behind the knee or in that distal SFA, just because of the vascular qualities of the stent itself. So it just depends on where you want to cut it off. I think something else that's really important to discuss is the way the superior releases is completely different if you're coming from up and over as opposed to if you're coming retrograde from the foot. So that takes a lot of different skill and approaching in terms of releasing the stent.
No, I think you're right. And that really comes in your point. If you're going retrograde, if you want to do an osteo SFA and nail it with a superior, the only way to do that is from retrograde because it's the distal end you can control, even no matter how good you are, the proximal end is not such a controlled thing. So your point is right, spot on. From antegrade, it's not a big deal. We can release it. We can go on high mag, slowly adjust it, and then release it. So I'm not concerned there. But the point's very well taken on the discrepancy of size here.
Maybe we can talk about, post-therapy medical management. The panelists here in terms of what they think this patient should get. This patient has no coronary artery disease, if I recall from the history.
I'll make a first stab at it. I mean, I don't think that the coronary disease would sway me one way or the other for this patient. I would, I think that the biggest question we still have is dual antiplatelet therapy for the first weeks or months after a scaffold placement. I think it's much easier to move to aspirin and Xarelto 2.5 milligrams twice a day for non-scaffold based approaches. I think most of us, especially if you do anything in the coronary, feel strongly that probably Plavix and aspirin is still worthwhile. So the biggest question here is, do you want to do dual antiplatelet therapy with Xarelto 2.5 milligrams twice a day up front, or you choose to stop the Plavix at a month or 3 months and replace it with the Xarelto, which I think is a reasonable alternative approach. For this patient, I think it all depends on the final result and the outflow. If you have good outflow and stent looks good and you feel confident without IVUS, Chris, that you're well opposed, that, I think that, dual antiplatelet therapy to start might be reasonable to reduce bleeding and then switching to Xarelto as your long-term kind of therapy to prevent long-term events.
So Eric, you're following.
Why do you switch? Because in Voyager, the addition of Plavix to aspirin 81 and rivaroxaban 2.5 for 1 month, Plavix didn't increase bleeding risk. So
it was you're right. It wasn't a significant increase bleeding risk. They definitely did still increase bleeding risk. It wasn't remarkable. I'll show the data. I think tomorrow we have a little bit of a Voyager talk built into medical therapy. But so, if they're a great triple therapy candidate and you feel comfortable with that, I think that's totally fine. I think it's just as we get our older population and more comorbid and have polypharmacy, I'd try to reduce those. We really don't do much on the coronary side with triple therapy anymore.
Would anybody do DAPT only on the panel? Mike, what's your thought?
I think the only consideration I have with using the 2.5 milligrams of Xarelto is one, the cost that patients incur, and then 2.5 milligrams, at least in Texas, isn't formulary. So, it's a burden that, we might place on patients. And then if they can't get it, they're not taking anything. And then you get stent occlusions that's the only consideration.
I think we have to go back to a very honest statement. No matter what we throw at this patient, if he keeps smoking, it's not going to really matter.
Correct.
Right? And that's just an honest statement. For me, we usually will be on dual antiplatelet therapy for 3 months because of the scaffolding placement and then switch over to Xarelto.
Yeah, and I'll just highlight, there is really no long-term data to support dual antiplatelet therapy. So if you are someone who uses Plavix for 6 months or 12 months, there's really, you're in a data-free zone and probably really just spending more time increasing risk of bleeding events.
You're in a data-free zone. You're in a data-free zone with short-term Plavix, short-term DAPT. There's no data in the peripheral space about DAPT. It's all in the coronary space. We just transitioned.
We're basically extrapolating from the coronary data.
But we decrease stroke and heart attack when patients are on DAPT.
Yeah.
So got that going for us.
I got to say, I agree with the panelists who said I don't do biopsies as a cardiologist, except an insurance biopsy when it comes to this. Come on down. Because if their insurance doesn't pay for the 2.5 rivaroxaban, I can give it to them all day long, and it's not going to work. And I'm going to really demand that he's taking statins and all the other things, and I'm going to try to convince him on Chantix as well. Because I think the smoking comment is right. Go up there, please. But anyhow, I think I like the rivaroxaban data as long as their insurance will go with it. Okay, down.
I love your focal force balloon here, Chris. It's a great idea.
Yeah. What we're doing, thanks, John. What we're doing now is really the distal part looked good with the DCB. So we're going to hammer the rest of it. I mean, that's not a technical term, but we're going to dilate the rest of it. And then we're going to put our Supera stent in across the knee joint.
Hey, Chris, talk, we have about 80 fellows at this year's meeting, so maybe talk to us about how you size your balloon when you're placing an interwoven nitinol stent or the Abbott Supera.
Yep, great question. So for Supera, it is a great stent, as common. It's the only one you can really, in my opinion, put behind the knee joint. But it's got great radial strength. It's more than 4 times any slotted nitinol tube, and yet it's conformable, flexible, and it will not fracture. But with that radial strength, if you don't prep this thing, 14, 15, then it will elongate and you lose all the beauty of these interwoven stent. That's going to hurt for a moment. Give him 50 of fentanyl, please. Down. And so you must pre-treat it. So if we're going to put a 5.5 Supera in, this is a 6.0 focal force at 14 atmospheres with fentanyl as we're doing that. And that's what our nurse, you guys don't see it. This team is so flawless. She's given that. I don't even have to look over. She's already done it. Go ahead. So now what we're going to do is just a quick poor man's Tennessee measurement. This is a 40 balloon. So I'm going to go down 3 times and see where 120 would end. So everybody watch the balloons with me. There's, that's 80. That's 120. So let's just get a 150. Supera 150, 5.5, 150.
So the idea of the Supera stent is it has, obviously for the fellows out there, has, really good crush resistance, but it doesn't have a lot of outward force. I think while you're doing this, Chris, we're going to do our last talk.
So let's just go back to the fluoro. All right, so let me go back here. All right, so here's this 5.5 Supera right above the knee joint. Remember the distal part was smaller. It was hit and looked very good with the DCB. Here's just a slow deployment that we spoke about, Ken and John and everybody, about just a high mag, well prepped. Look how good that looks right out of the box. Here's a coronary cine angiogram. You can see the calcium there, and look how well that stands up to it. We added a short Supera above that, and here's our result in the SFA. And here's our result in that pop, including the DCB distally. So, I think we're happy with that. We're going to do some final runoff pictures towards the foot. Let me ask the panel before we go with 1 minute left. How do you balloon tamponade the posterior tibial when you take the access out? What's your thought on getting the, we're going to obviously just hold pressure. It's right there. But do you do any balloon tamponade or just hold pressure and then take angiograms?
Maybe we can go quick.
If we're doing a tibial intervention, we're down there, yes. Otherwise, in this case, no.
Yeah, I would just be holding pressure.
Eric?
Exactly.
Perfect. Yeah. We've got great pressure holders right here.
I think everybody's in agreement, Chris, that if we're not intervening there, we would just hold pressure rather than traumatizing the vessel for no reason. Yeah,
it's a one runoff vessel. The last thing we want to do is hurt that vessel. So what we'll probably do is hold pressure, leave them on the table, take a picture, make sure we have beautiful runoff to the foot, and only if we needed to then do something down there.
Yeah, and realistically, light pressure, patent hemostasis, it'll basically stop pretty quickly, as you know.
Chris, great result. I just want to add for the fellows in the audience, if you're using Supera for the first time, the best thing that you can do is get a blank Supera outside the body, put it next to the vessel that you're deploying, so you can get an idea of what maximal deployment's going to be. Chris, the only thing that I would add to you is the overlap that you put in when you put the second supera in, I was watching the way that you deployed it. Have you ever thought about using a kissing technique where you kind of flower it and then push it up against the edge as opposed to being overlapped? I know we're used to overlapping in the coronary space, but with the way the supera is designed, being able to get it to maximally deploy circumferentially, you kind of inhibit that at the point where you overlap.
So if you saw, what I usually do is start deploying it, pull it back so there's a half centimeter of overlap. And what I've found is if you don't, later you see this little gap between, because the supera can work itself out. So there's no perfect answer. You are putting a stent that has a little more metal in a stent that has a little more metal. So your point's well taken about minimizing overlap, which I agree with. I just tend to go a little bit, and I've done this for, a long time. I won't say how long. And we've had long-term follow-up and long lesions that tend to be pretty good. But I think good points. The only other thing I would add to your comment about learning supera, I agree with you. The other thing is to come to Kingsport, Tennessee. We'll do a supera course with you. If you'll publish my phone number on the screen and reach out to your local Abbott reps, and we would be more than happy to entertain you in Kingsport, Tennessee.
Thanks. And you get to stay with Dr. Metzger, so when you go. So
You get some bourbon down there, right?
Great case. Want to thank you and your team. You guys did that in rapid pace. Want to thank our speakers.